of air leaks following lung resection. Here is how this seminar goes on with the contents of introduction, assessment of air leaks, risk factors which can cause air leaks, and preventative measures. And then management in the post-operative period, post-resection, and then bronchopleural fistula. So air leaks, simple definition is like
bronchopleural fistula can be a separate topic because there are a lot of things to discuss on that.
Yes,
anyway, let us see how much you'll go, how much time
kept some slides for completion purpose because. So simple definition is air escaping the lung parenchyma into the pleural space after any kind of surgery within the chest. It can be active air leak or passive air leak. Active air leak can be alveolo-pleural fistulas, APFs, communication between the alveoli and the pleura, where pulmonary parenchyma and pleura distal to the segmental bronchus. And then bronchopleural fistula is communication between the bronchus and the pleura, main stem, lobar or segmental bronchus, which in communication to the pleura. Passive air leaks are persistent space without any parenchymal source of air leak. Distinction is important because therapeutic implications and management principles are different in both. So pulmonary resections commonly result in air leaks from the residual lung tissue. Chest tubes are placed in postoperative period to remove air and facilitate lung re-expansion. Apposition of the lung to the chest wall helps to seal the raw surface, often the source of leaks. Typical duration for this apposition will take around 2 to 5 days. So prolonged air leak is nothing but air leak persisting for more than 5 days postoperatively. Most common post-op complication after an elective resection. Incidence of air leak post-lung resection is around 25 to 50% on POD1, whereas it reduces to 20% on POD2. At last, prolonged air leak incidence after a lobectomy can be around 10.5%, and a wedge resection can be around 4.1%. So comparison of techniques, even in minimal invasive versus robotic, there is no it shows a similar rate of air leaks, and clinical relevance is prolonged air leaks can lead to prolonged chest tube in situ, which increases the post-op pain, and then respiratory splinting, increased risk of pneumonia, diminished overall mobility, for which they will have progressive muscle mass loss, increased necessity for external procedures, readmissions, cost implications, psychological issues, increased overall morbidity and mortality. For assessment, first we have qualitative and quantitative. Qualitative is the most widely used technique which we use mostly in the clinics while clinical examining, asking the patient to cough while observing the water column and the water seal. No bubbles in the water seal, that means airtight lung. Presence of bubbles, that means that there is air in the pleural space, doesn't mean active or passive. And then we asked him to cough repeatedly if there is a bubbles in the underwater seal. Then on repeated coughing, appearance of bubbles with same intensity suggests of active leak. Repeated coughs, reduced intensity and stops. That means that it may be small active leak or can be passive leak also. And then before deciding to pull out the tube, repeat this after an hour to exclude any active leaks, and then can be removed. Bubbles occurring in the normal breathing while patient speaks, that means that it's significant active air leak. So strategy to apply suction to chest tubes varies among surgeons and institutions. Drain management and drain removal algorithms are more intuitive. The digital and continuous air leak measurement, ability to plot the amount of air leak over time. Solid information for quality assessment and straightforward clinical decisions leading to shorter hospital stays. Only few publications have been specifically addressed this issue in order to assist surgeons in this decision. At least modern digital chest drainage systems with air leak meters allow for quantifying the air loss over time and visualization of the trend of the air leak. In the absence of clear cut of magnitude for an air leak, each surgeon or institution has to base their indication to reopen upon their own experience with their and with the chest drainage systems. Quantitative assessment grading, Macchiarini et al. Suggested a way to classify the air leak. It is grade 0 to 3 with no leak to countable bubbles and then to stream of bubbles. At last, it's continuous bubbles, coalesced bubbles. Cerfolia classification of air leaks, which we use day to day, most of the times, which is grade 1 to 4. Grade 1 is on forced expiration. That means typically when the patient is coughing, if the bubbles are coming, it's grade 1. And then 2 is expiration only. 3 is inspiration only. See, 4 is continuous bubbling present in the air leak chamber during both inspiration and expiration. Robert David Cerfolia classification system. It has both the aspects, which is called qualitative aspect along with quantitative aspect. So qualitative aspect is based on when it occurs during the respiratory cycle. That means the same as we saw previously, that is continuous, inspiratory, expiratory or forced expiratory. Qualitative, how big is the air leak? So forced expiratory leak, only with forceful cough, not with deep inspiration or expiration. Forced expiratory leaks are the smallest, followed by expiratory and then inspiratory and then finally continuous. So Robert David Cephala classification system, air leak meter looks like this, which has 1 to 7 levels, complete scoring of air leak, bedside assessment by watching which one of the 7 chambers the bubbles go when the patient is coughing. Here in this image, it is seen that level 1 there is bubbling. In the same way, if you see bubbling in the 7th, this thing, and if it continues, it is the maximum air leak which a patient can have. So it is a reproducible, less inter-observer variability and spectrum. From the smallest one is forced expiratory and level 1 is the smallest and the largest one is the continuous and level 7. So air leaks score can be given based on this. Leaks are assigned a numerical value for statistical purpose from 1 to 28 for a comparison. There are some analog devices in which this is incorporated, plurivac, which we see sometimes. And then there are some digital devices also, which quantifies air leaks in ml per minute, average air leak displayed over the different times of increments, ability to assess air leak healing also, depending upon the trend which is shown in the graph. And the only unit, this is the only unit which provides information about the maximum and minimal pleural pressures also. This is the one which we use in our institutes, that Medela, that is SOPAS. The quantification of air leak can be done in this. With it is that it applies uniform suction pressure throughout the thoracic cavity, also throughout the different phases of respiration. It is also able to provide suction if needed as the patient ambulates also, because it has battery backup. Now coming to the risk factors of the patient for having an ear leak. Patient-related factors like COPD or underlying lung disease.
You should have talked about the Atmos device as well, because that is a new one which has come out. Topaz is sort of becoming less popular because they don't have good service this thing. So the Atmos is the alternative. Should have found out about Atmos device.
Okay. Actually, we day to day we see only plurivac in this one. We don't know that is the new one. Okay, sir, I will add it.
No, plurivac is just a passive thing connected to wall suction. That is not the thing. Atmos device is like Medela. It is a digital device which controls everything, and it is a digital battery operated digital device. Find out about Atmos.
Okay, sir. Then risk factors, patient-related risk factors, chronic obstructive pulmonary disease and other underlying lung diseases, female gender, low FEV1, smoking history, increased age, diabetes, chronic steroid usage. Along with that, patients who are on chemotherapy or radiotherapy. Radiologic or anatomic features are upper lobe emphysema changes, diffuse emphysema with large bulbous changes. Procedure related, especially for lobotomies, emphysema, steroid use, upper lobe resections, bilobectomies, surgeon-related variations. Air leak rates may vary between the surgeons. Open thoracotomy may be associated with higher air leaks compared to minimally invasive procedures. And anatomic explanation for a variation by lobe is that lower lobectomy has a lower leak rates. Reason being flat surface of the remaining lobes and the diaphragm elevation improves lung chest wall apposition. Upper lobectomies often leads to poor conformation to the apical chest shape, limiting opposition and seal. So measures to prevent the post-op air leak, pre-op, intra-op, and post-op measures. So coming to pre-operative measures, we have to optimize the patient with deep breathing exercises, volume spiral, chest physiotherapy, and nutritional rehabilitation. Intraoperative considerations, preventative techniques to avoid air leaks during pulmonary dissection are the gold standard. Use meticulous dissection techniques, gentle lung handling with clamps, precise hilum and fissure development, avoid blunt dissection due to risk of tearing the visceral pleura and the worsening air leaks. Use electrocautery and sharp dissection for non-filmy adhesions and release all the adhesions. Fissure dissection is challenging and a common air leak source. Meticulous technique minimizes leaks. People use a fissure-less technique or fissure-less surgeries for avoiding this, and use staplers to avoid incomplete fissures, reducing leaks. Consider fissure-less lobectomy techniques using stapling lung parenchyma without dissecting the fissure. For segmentectomies, define segmental plans with the staplers instead of blunt dissection to reduce the air leaks. Manage specific fissure air leaks with the direct suturing, buttressing with pleura or surgical. There can be procedures which can be done in intra primarily that are pleural tents. Pleural tent is nothing but creating a tent of pleural tissue to reinforce the pleural space after surgeries. After performing a lung resection, the parietal pleura is stripped off from the chest wall and ligations are applied to secure the pleural tent and lung parenchyma. The pleural tent after use after pulmonary resection has been shown to reduce air leak duration, chest drainage time, and hospital stay in length. This is the mobilized parietal pleura. After that, it is attached to the upper surface of the lung. It is especially beneficial in upper lobectomies where air leaks are more prevalent. Regression analysis identify pleural tenting as a strong predictive factor for reducing prolonged air leaks and recommended when extensive air leaks originate from the raw surface of the remaining lung after upper lobectomies. Chest tube placement strategy. At least one chest tube should be placed underneath the pleural tent to assist with the suction and promote lung pleura apposition. Consider pleural denting as an valuable adjunctive technique for managing difficult air leaks and improving recovery outcomes. Coming to sealants, some main classes of sealants include fibrin glues, synthetic sealants such as glutaraldehyde, albumin, polyethylene glycol, and collagen patches are designed to reduce post-operative air leaks after pulmonary resection. These are some of the examples which we see: BioGlue and Tissel. There are many more commercially available sealants. However, data on efficacy is variable and inconsistent. A recent meta-analysis reported only modest benefits in reducing prolonged air leaks across various sealants. A Cochrane's systematic review found only 6 out of 16 studies demonstrated reduced post-operative leaks. Merely 3 studies indicated quicker chest tube removal and shorter hospital stay. Level of evidence is very low. Overall, current evidence doesn't strongly support that systemic use of sealants significantly reduces length of hospital stay or clinically meaningful air leaks. Next one is suture line buttressing. Staple lines is a common site for post-operative air leaks, especially when the lungs underlying lungs are bad, like COPD patients or in extensive COPD patients. So buttressing using bovine pericardial or PTFE strips can be used. If the staplers are already having this buttressed material, we can use it. If not, we have after stapling the lung, we have to buttress with our sutures. So, a national emphysema treatment trials reported no significant benefit in reducing air leaks with staple and buttressing. A multi-center prospective randomized trial found no statistical difference between buttressed and non-buttressed groups. Though there was a trend towards shorter air leak duration and earlier chest tube removal in buttressed patients. That means there is some difference, but there is no statistical difference. Buttressing may be considered in high-risk patients, but evidence does not conclusively support routine use. Coming to muzzle flaps. Muzzle flaps are useful for covering areas prone to large postoperative air leaks. Intrathoracic muzzle flaps minimize the risk of pleural space formation by opposing the muzzle to the lung surface, thereby reducing the air leak. So muzzle flaps can be used to buttress the bronchial stems after pneumonectomies or upper lobectomies at risk of air leaks or complications. Best applied when the need is anticipated preoperatively only. Uh, Particularly beneficial in patients with extensive emphysema, where the remaining lung might not fully occupy the pleural space, leading to prolonged air leaks. Muscles should be mobilized early during surgery to allow early transposition into the pleural space if required. Next one is pneumoperitoneum and phrenic nerve paralysis. Pneumoperitoneum is reducing the pleural space size can be achieved by changing the diaphragm position, either by phrenic nerve paralysis, used usually temporarily and not widely practiced. And another method is creating a pneumoperitoneum, which elevates the diaphragm and opposes to the lung undersurface. So pneumoperitoneum, we can see it can be done in these two ways, where your peritoneal dialysis catheter is kept under the diaphragm, and then air will be insufflated through that at regular intervals. And then other one is creating initial pneumoperitoneum with various needle, and then if needed with a catheter or not, or as a single stage. So pneumoperitoneum involves placing a peritoneal dialysis catheter and injecting sterile air 500 ml into the abdomen. This is the phrenic nerve. During intraoperative procedure, some people will crush it. Uh, some people will inject lignocaine around it. Some people will inject bupivacaine around it. Some people uses post-operative. There are some studies which are showing post-operative placement of catheter to the phrenic nerve in the neck under ultrasound guidance with the help of anesthetist, and then continuously infusing lignocaine plus bupivacaine infusion till they achieve the diaphragm movement, till they achieve the diaphragm palsy, which is temporary, which can be recovered after removing the catheter from the neck. So the patient should be nursed in an upright position after diaphragm elevation. Air usually absorbed in the peritoneal cavity, so repeated injections may be necessary. Best applied in patients undergoing lower lobectomies or bilobectomies with residual pleural space, shown to shorten chest tube duration, hospital stay, and reduce residual space. Also effective after upper lobectomy by elevating diaphragm and remaining lobes to reduce apical space, helps to maintain persistent air leaks, manage persistent air leaks. Coming to the post-operative settings, so it's like intra plus post chest tube drainage. First, placing your chest tubes. Initial post-operative management after lung resection involves the chest tube placement to evacuate air. So chest tubes size and number vary by surgeon preference. Commonly 28 to 32 tube is used. Typically one chest tube is placed anteriorly for evacuation and one in the posterior for fluid drainage. Historically, suction application has been standard practice to assist lung re-expansion. There is ongoing debate of whether suction is beneficial or possibly harmful, but most surgeons still use in the initial postoperative period, they will use suction. So the extent of air leaks the suction level. Larger air leaks often leads to increased suction to reduce pleural space. Care must be taken to balance the suction intensity to avoid causing additional lung injury that can worsen or perpetuate air leaks. This tailored chest tube management is crucial for effective control of postoperative air leaks and lung re-expansion. So digital versus standard wall sections. A digital one is Atmos and Topaz. And advantages are that putting these devices in the initial intra post-op is that mobility can be increased and graphics can be seen at the real time and can be recorded over the last 24 hours. 24 hours. So level of suction to be connected on the chest tube. Suction application to the chest tubes post lung resection is variable and debated. Some believe suction improves visceral, parietal, pleural adherence and promotes healing of air leaks. Others argue suction may keep parenchymal fistulas open and cause further lung injury, especially in emphysematous lungs. Prospective studies show no significant difference in air leak duration between suction and water seal methods. It's only water seal methods. Water seal may be better for stopping smaller air leaks, but can fail with larger leaks and cause pneumothorax if leak persists. Use of suction should be individualized, possibly using minimal and limited duration of suction when feasible. Water seal may unintentionally create new pleural space, which can lead to persistent leaks or empyema if undetected. Maneuvers for persisting air leaks include gradually pulling back the chest tube to allow the lung position to the chest wall, and removing and repositioning the chest tube to help obliterate the air leaks at that place, promoting lung chest wall contact in the previous place where the chest where the drain is there. And decisions on suction and chest tube management requires careful patient specific considerations to optimize outcomes. These are some ambulatory drainage options where on prolonged air leak we can discharge the patients with these things. These are there are Heimlich valves and portable drainage valves allow chest tube patients to ambulate freely without bulky drainage canisters. Heimlich valves primarily function to drain air leaks. Portable chest drains can evacuate both air and effusions via small connection canister. So this is the pneumostat which will have a small small canister. This can be connected when patients with prolonged air leaks without much collection which is coming every day. This is how the Heimlich valve work. This is the inlet nozzle, and then sleeves closes, preventing black flow there. Only the flow from inside to the outside will be allowed through this thing after connecting to the chest tube. So best suited for patients with small, stable air leaks and lungs that remain expanded on water seal. Caution required due to the risk of infection and tube dislodgement can happen. And hospital discharge with Heimlich valves for prolonged air leaks has been associated with significant rates of empyema, that is 70%, and readmission 26%. Patients can be safely discharged if no subcutaneous emphysema or worsening pneumothorax occurs, confirmed by chest X-ray after putting on that portable devices. Follow-up involves clinical evaluation and checking for air leak by placing the valve under seal and observing bubbles. Chest tube removal is safe if no air leak observed, but requires a confirmatory chest X-ray post-removal. This ambulatory approach can improve patients' mobility while managing prolonged air leaks, but requires careful monitoring to prevent complications. And then next one is options for managing air leaks that fail long chest tube drainage. Chemical pleurodesis and muzzle flaps. So chemical pleurodesis uses sclerosants such as talc, doxycycline, bleomycin, tetracycline to induce an inflammatory response that cause pleural adhesion and seal air leaks. Success depends on direct apposition of visceral and parietal pleura for effective pleural scarring, and then a retrospective studies show success rate of up to 97% with mean air leak duration for pleurodesis around 2.8 days. This is the 2 grams of vial of talc powder. So procedure is installed 4 to 5 grams of talc or 500 mg doxycycline via chest tube. Reposition the patient to evenly distribute sclerosant along the pleural space and hold drainage temporarily. Pain control includes pre-medication with the 250 mg lidocaine installation to reduce discomfort, and pleurodesis can be repeated 2 to 3 times. But failure beyond this suggests limited efficacy. After pleurodesis, resuming suction helps in reinflating the lung and achieving pleural apposition. An algorithm for pleurodesis typically allows for spontaneous resolution of air leak over 5 to 7 days after intervention. Failure with persistent space and leaks, especially with foreign body reaction to talc, may necessitate surgical muzzle flap used to obliterate the space, and then the seal the active air leak area. The pectoralis major muscle flap can be mobilized through a small axillary incision transposed intrathoracically via rib segment to fill the space and buttress lung surface, effectively sealing persistent air leaks. This combined approach offers options when prolonged chest tube drainage fails to resolve air leaks, balancing medical and surgical strategies. The other one, which is mentioned, is autologous blood patch pleurodesis. Here is also same mechanism but using autologous blood. So mechanism involves a direct sealing of the air leaks with the blood clot above the lung and subsequent inflammation leading to the pleurodesis. Optimal volume of blood ranges between 50 to 120 ml for effective treatment, safe, inexpensive, and associated with good success rates post pulmonary surgery. Around 92.7% overall success, but there is a risk of increased, but there is increased risk of infection. Approximately 76% of the patients achieve success after a single injection. Monitor for chest tube patency, as after giving the blood, it may clot in the tube and then it may block the tube. Other options are that endobronchial valves, bronchoscopic interventions using unidirectional endobronchial valves targets prolonged air leaks. Valves are placed into lobar or segmental and when going further subsegmental bronchi to allow air evacuation and promote healing. No large randomized trials currently support this widespread use. Evidence no is limited to case reports and small series. In a series of 75 patients, the reported median time of air leak resolution is about 16 days. Potential complications include empyema and contralateral pneumothorax. If this approach is particularly suitable for patients who are unfit for surgical repair and who are high-risk surgical candidates to undergo a reoperations. Endobronchial valves offer a minimal invasive option for managing persistent air leaks when surgery is not feasible. And reoperative approaches for prolonged air leaks. Reoperation is considered based on the extent and progression of air leak. If the air leak shows improvement over time, observation may be preferred over immediate surgery. Exception is that sudden development of air leak after initially minimal or no leak in the postoperative period suggests stap line separation warranting urgent re-exploration. Suspected bronchopleural fistula requires bronchoscopy for evaluation, confirm the defect necessitate early surgical intervention. Reoperative techniques include previously described methods, that is pleural adhesion via sclerosins, mechanical pleurectomy, sealant application, overstapling of lung parenchyma, use of muscle or momentum flaps to reinforce the leak, pleural tenting and stapline buttressing to cover and obliterate fistula. Surgical intervention should be individualized, balancing patient condition, air leak characteristic, and pre-interventions to optimize outcomes. So residual spaces following lung resection are common after a large pulmonary resections, but usually little consequence if no air leak is present. The body compensates by hyperinflation of the remaining lung, diaphragm elevation, and the mediastinal shift to minimize this space. And residual spaces without air leaks typically fill with fluid which is absorbed or contracts over time, often requiring no interventions. Patients with underlying lung disease are more prone to residual spaces. A residual space with a new air fluid level, fever, leukocytosis suggests postoperative empyema. Diagnosis is confirmed by aspiration of that fluid and then sending for cultures. Early management includes chest tube drainage, persistent infection or space requires further interventions. In non-infected cases, muscle transposition can fill the cavity after cleaning. In gross infection, open drainage followed by muscle transposition or a Claggett procedure, that is wound cleaning, antibiotic irrigation and closure is performed, which showing 75 to 90% success. Failure of Claggett procedure may necessitate muscle flap obliteration of the residual space. Persistent air leak with residual spaces may require reoperation with a fistula closure and muscle transposition. Treatment must be individualized. Coming to bronchopleural fistula, the reported incidence is between 1.5 to 28% for a pneumonectomy, while the rates of bronchopleural fistula following lobectomy are as low as 0.5%. Mortality rates associated with bronchopleural fistula ranges from 16 to 72%. It can be as low as to the 70, can be high also. There is a higher incidence reported for right pneumonectomy and right lower lobectomy. Bronchopleural fistula is significantly more prevalent in malignant conditions as opposed to benign conditions. Recipient of radiation and chemotherapy. Self-explanatory statements. And then usually 7 to 15 days following lung resection, uh, this can happen early. It is called early if it happens in 7 days, and then intermediate is till 1 month, and then late is more than 1 month. As complication of pulmonary infection, any time during the course of illness, it can happen. Early indicators are reappearance of fever, increased cough with purulent or serosanguinous sputum, persistent bubbling from the chest drain. Then, if we are suspecting this thing, we have to do a plain X-ray, which may reveal following features of bronchopleural fistula: that is, steady increase in intrapleural airspace, appearance of new air fluid level if it is not there previously, and then development of tension pneumo or drop in air fluid level, which is there previously, exceeding 2 centimeters in the absence of chest tube. So this is how tension pneumothorax or pulmonary flooding can happen. This is the reappearance of air fluid level, or if it is there previously, if there is a drop more than 2 centimeters. There can be subcutaneous or mediastinal emphysemas or mediastinal shift to the opposite side against what we observe. And then there can be pulmonary flooding in the opposite side due to the transbronchial spillage of the contents from this side to that side. Role of CT: demonstrate pneumothorax, pneumomediastinum, underlying lung pathology, demarcation of actual fistular communication sometimes, role of fiber optic bronchoscopy, then it can confirm and localize the bronchopleural fistula where it is. And then fiber optic bronchoscopy and selective bronchography has to be done. Visualization of the continuous return of air bubbles and bronchial wash also, it tells us there is a fistula in the distal segments. Selective installation of methylene blue into segmental bronchi appears in the chest drain or in the sputum also can confirm the level of bronchopleural fistula. So persistent pneumothorax, air escaping through the bronchopleural fistula, delays healing of the tract, inadequate ventilation because of significant loss of tidal volume and pendulum of that is when the mediastinum is mobile, it keeps on moving with every respiration, and V by Q mismatch. Infection of the pleural space. Most common cause of death in bronchopleural fistula is aspiration pneumonia, ARDS, and tension pneumothorax. Treatment options include surgical procedures, medical, and bronchoscopic guided placement of many things like glues, coils, sealants, balloons, etc. So initial treatment is control of life-threatening condition. That is, if there is a tension pneumothorax, urgent insertion of chest drain, and pulmonary flooding, immediate airway control, postural drainage with affected side down, major bronchial stump dehiscence if it is suspected, then immediate resuturing with reinforcement has to be done. So aggressive management of the underlying comorbidities also to be done, which may need ICU setup. That is, hemodynamics has to be done, and superadded sepsis has to be managed with nutrition, hypoalbuminemia, anemia has to be taken care, unresolved empyema, underlying tubercular or fungal infection has to be taken care of. Poor candidates for a second surgical procedures with all these patient with all this being having patient and need ICU setup. Surgical procedures include decortication of that side, preservation of that bronchial stump, and then closure of the fistula with a muzzle flap from the intercostal space. This can be done in the initial procedure also, and thoracoplasty combined with pedicle muzzle flap to cover bronchial stumps. Resection of diseased chronically infected lung segments if there are any. Then other minimally invasive techniques are endoscopic valves, endobronchial balloons detects the air leaks, insertion of endobronchial valve into the segment, and then segmental endobronchial blocking. So how it is done is 5 mechanical breaths will be asked to take with a balloon when after deploying a balloon. Air leak cessation means that is the culprit area. Then we have to place that endobronchial valves there, which can be removed after 6 weeks. And there are other devices also, which are ambulance devices, which is mostly used for sealing the ASTs in cardiac this thing. It has an nitinol mesh with polyester cloth inside. Combination is early coverage and encourages the growth of the tissue over the device. And there are got silicon made bronchial fillers to treat the intractable pneumothorax and bronchopleural fistulas, and then previously shown endobronchial valves. So localization of leak with a bronchoscopy and balloon occlusion. Balloon inflated in ipsilateral main bronchus first, then decreasing the rate of air leak in water seal observed for 5 breathing cycles. Sequence repeated, advancing it distally in the lobar bronchus first and into the segment, and then subsegmental bronchus airways, so that we will get the location of bronchopleural fistula. So advantage is decreased hospitalization and pleural drainage days, feasible and safe, successful reduction of air leak in the majority of the cases. Valve placement in bronchopleural fistula, more than 5 days can be done after more than 5 days of bronchopleural fistula and proper management. Air does not enter the pleural space, enabling lung re-expand and heal spontaneously. This they allow for expiration and clearance of bronchial secretions, reducing the risk of pneumonia also. Thank you.
Mohan.
Yes, sir.
This was a very cursory presentation. It looked like you got a chat GPT to make a presentation last night and then just compiled a few slides in this thing. You've been with me for 1 month. You could have discussed these things and I said, I'm going to do this talk, and I would have told you so many things that you missed. Most of them are practical things. Okay. So,
Yes.
and you combined three major topics into less than 1 hour. You finished by in less than just about a half an hour. That is persistent air leaks, and then residual space, and then bronchopleural fistula. These are the most important complications for a thoracic surgeon. So you cannot just brush it off like that. To begin with, you have to define what is alveolar leak and bronchopleural fistula. Alveolar fistula and bronchopleural fistula. As you said, you just cursorily passed it off, which may saying that the management differs. In alveolar fistula, which follows lung resection, where there is incomplete fissure or there is parenchymal damage, there is bubbling of air in the chest tube. Most of the time, pulmonologist will tell you that there's a BPF. BPF means the definition of BPF is there is a communication with the segmental bronchus or more proximal. Anything distal is an alveolar pleural fistula, which is from the parenchyma. And in the parenchymal leaks, all you need to do is wait and watch, get the lung expanded, and then it gets adherent to the chest wall, and then treat it. You don't require an operative procedure for that. Whereas a BPF always requires an operative intervention to close that fistula. And how we decide and what we do, I will come to that. Okay.
Okay.
So BPF and alveolar pleural fistula has to be differentiated before you decide what is the treatment modality. See, unlike in the thing in thoracic surgery is after lung resection, you have to get the lung expanded and get adherent to the chest wall within 48 hours. If you miss that boat, then the lung will never come up, and then another rind of pleural thickening will occur, and then it forms into residual space. So the first 48 hours is the most crucial thing. And unfortunately, unlike in cardiac surgery, if the blood pressure is low, you can just hike up the inotrope and then it goes on. But whereas in thoracic surgery, the patient's own effort is most important. So that means you have to do active physiotherapy, good pain control, and then diligent pulmonary rehabilitation to get that lung expanded. If you lose 48 hours, then you're finished. Second, then the classification you said, yes, Sartorius classification is the most commonly used thing. Why this classification came about is because everybody, each one had his own way of saying, small bubbles, few bubbles, multiple bubbles, enormous bubbles. So it was individual assessment, but everyone had to be on the same page. So that is why they divided into forced expiratory, expiratory, inspiratory, and continuous. So that is how you can grade the amount of air leak that happens and then plan your treatment subsequently. So that portfolio with each of these grades divided into 7 levels was utilized, and it was also incorporated into many of the commercially available drainage systems. So before that, you should have talked a little bit about the amount of suction that is used. If you connect it to a wall suction thing, it is 100 centimeters of water. Whereas if you connect it directly to the ICD bottle, the whole lung will be in your bottle. So you have to reduce it to minus 10 or minus 20, maximum minus 20. And how do you do that? In the olden days, we did the 3-bottle suction. So that you could this thing. So if you had talked a little bit about the suction, 3-bottle suction, you would have got the principle of chest drainage. I mean, suction, and then when to use and what to use. You should have given some things about when to use and what to use, when to use suction and when not to use suction, and that is a fairly long thing. So that is about drainage. Then you could go on to the commercially available combined thing, which combines the 3-bottle suction and the air leak, and then there's also a meter which gives you how much suction that is applied into that device from the wall suction. So that is there. Then, of course, nowadays you have the digital suction. Digital suction is much more efficient and then easy to manage, and also makes the patient ambulant. So, but however, it is expensive. So you have to talk about the pros and cons in our setup. So you just can't say, like my famous quote, 3 A's, don't ape everything that is available, all that is available in the Western literature. Adopt, adapt, and apply to your own environment. Then coming to the pre-op, you said about what are all the things that to do: smoking, cessation of smoking, optimizing COPD, making sure that things are nutrition is good and all that, and then steroid. If somebody is on steroid, should get the steroid down to prevent air leaks. But in the operative things, you just didn't mention many things that are done on the table. One is, of course, meticulous dissection, meticulous this thing, use of staplers nowadays, and use of tissue sealants. So where you should have talked about a little bit about the mechanism of the tissue sealants, the glue, fibrin glue, and then the tissue patch, and then of course you can use blood patch also on the table. Okay.
Yes.
So, so these things are important. Next would have been, you should have talked about pleural talc pleurodesis. Although the physicians use this indiscriminately, the actual way the talc pleurodesis helps is directly under vision in the operative setup, so that you distribute the talc all around, both on the visceral and the parietal pleura, put proper ICD tubes, and get the lung expanded within 48 hours. That is how it works. The commercially available sterile talc that you talked about, and then put it into the ICD. Many people don't know how to do it. See, that once it is not just injecting into the ICD and then clamping it and then taking it out, because many a time, almost 90% of the time, they create loculations. They create loculations, and subsequently you have to go back and then do the decortication and then subsequent pleurodesis that you have to do. Talc pleurodesis, pleural tent is okay. Pleural tent is important. And sometimes when we do talc pleurodesis, we also use it for simple small apical bullae. Once you stapled it or taken a wedge, you can put a talc there right onto the top called epi. It is also, and also strip the apical pleura down, and so that it adheres to the upper surface of the lung, called apical pneumolysis. Then you have the management of the pleural air leaks. Now, air leaks, you should have talked about these things. And then there are certain times on the table, you must make sure that the lung is expanding and is capable of expanding and coming up to the chest wall. If not, if you have taken a diseased lung and the rest of the lung is also not very good, and if there is going to be residual space even on positive pressure on the lung when you are before closure of the chest, you have to, there are certain things that you can do. You mentioned about phrenic nerve palsy. Nobody uses pneumoperitoneum now. It is only mentioned in the books, but nobody, in my 45 years, I have never done a single case of pneumoperitoneum. So the other things that can be done is you can cut the rib above and below, one in the posterior angle and one near the sternum. So above and below, so that the chest wall sort of collapses a bit. This is the standard thing that happens in nature after a pneumonectomy. The ribs get crowded, the diaphragm gets elevated, and the mediastinum shifts. Similarly, you can do the same thing. So you can get the diaphragm up with a phrenic nerve palsy. Nobody does phrenic nerve crush or phrenic nerve excision nowadays because that loses the respiratory dynamics. So people do this temporarily to get the diaphragm up so that the lung comes and sits on the diaphragm, gets adherent in 24, 48 hours, and then you're back to normal breathing thing. That is how phrenic nerve palsy helps, not crush, because you have permanently destroyed the phrenic nerve in that situation. So then this is called shingling of the ribs, so that try and get the space down. And then vigorous physiotherapy, properly placed chest tubes play a very important role in getting that residual space obliterated. Then next, you never talked about thoracoplasty. Thoracoplasty, although is not done in the primary setup, it is a very useful procedure done after 2 to 3 months of vigorous physiotherapy and extensive this thing to get the lung expanded. If it still doesn't happen, then thoracoplasty is an option that you can do. And then coming to bronchopleural fistula, you talked about this thing. First thing is to do is that a bronchopleural fistula should be treated by surgical intervention most of the time, because if there is a significant bronchopleural fistula more than 5 millimeters, any non-invasive technique will not work. And before that, recognition of bronchopleural fistula in the postoperative ward is most important. The first sign that a patient has when he has a bronchopleural fistula is his voice changes. Phonation becomes difficult. So that is the first thing. Then he starts coughing copious purulent sputum, and that can spill over to the opposite side. So the immediate thing to do is to put him on a lateral position with the operated size dependent, so that the open bronchial stump is above the level of the fluid, and then you insert an ICD, because in the best of the centers, to put an ICD, it takes 20 minutes minimum 20 minutes to arrange things and put an ICD. So by that time, if there is spillover, the opposite lung is destroyed. So you have to put him in a proper position, then put an ICD, and then do a bronchoscopy, and then assess the size of the fistula. The fistula, if it is less than 2-3 millimeters, maybe this glue or coils and other things may help, but definitely not very good, although the physicians will keep on telling you 101 statistics about it, but they never work. The ideal thing is to go back and resuture it, reclose that stump, if necessary, or more often than not, put a muscle flap or an omental flap and then close that fistula. If there is still a residual space, you can fill up with omentum or a muscle flap. If there is a BPF following a post-pneumonectomy empyema, then in such a situation, it is better to go through virgin territory, through a median sternotomy, access the bronchus between the aorta and the SVC, and then clamp it or suture it at that time. So this is how bronchopleural fistula is managed. So all these things are, you missed all these things in your ChatGPT presentation. Looks like that. Yeah. So, it was a very cursory presentation. I am sorry, Mohan, because there are a lot of important things, a lot of practical things that you had to mention about, and to the latest issue on European Journal of Thoracic Surgery, Cardiothoracic Surgery is EJCTS 2025. There is a special supplemental issue and they call it drainology, the management of chest drains. It is a whole supplementary issue with at least about half a dozen articles. So you please get into read those things and then try and incorporate that into your day-to-day practice. It is available on the EJCTS. I think it's available on the clinical key also. I don't know. I'm not sure. Okay.
Yes.
So these are the three most important topics. Each one should have been discussed separately, not in one go. And you've been with me for 1 month. You didn't even discuss these things. You just called me last night and says I'm speaking on this. That's not fair. That's not right. Okay. Any other comments?
Nothing very much to add, except that the earlier mainly usually after thoracic very often it's a alveolar pleural fistula actually. That's a more common. The bronchopleural is now much less because all surgeons are expert how to close the bronchus by stapling or suturing, so this is very common. And then it's much more common. You said it's less common in the lower lobe. It's mainly because whether the fissure is complete or not. The oblique fissure is often complete except the between the superior segment and the upper lobe. That may not be complete. And the between the lingula and the upper lobe may not be complete. So those are the conditions where there may be alveolar pleural fistula occurring. And it's also occurring more common in segmental resection. What is the landmark in segmental resection between the segments? What structures demarcate? Huh? It's a pulmonary veins,
Yes.
So actually, that's how you see when you do a segmental resection and you find the veins, bleeding from that. You have to take care of all that. Sometimes you do the water test and see whether there is any bubbles coming. You have to take care of that. If you don't do that, actually, there's a problem. which leads to prolonged air leak. And as you said, the chest tube is two chest tubes are inserted. The anterior one goes to the apex. Um, and about you said some surgeons don't use suction and all. We always use suction, and the higher suction is 20 centimeters of water. The lower suction is 10 centimeters of water. So depends, as Krishna has said, within the next day or next 2 days, the lung expands fully, and then there is some air leak. Then actually you should reduce the suction, because sometimes the holes in the uh, chest tube directly sucks through the small alveolar pleural fistula and it persists, so the reduce the suction, and we used to stop the suction and say, see whether sometimes when you stop the suction, the leak from the alveolar pleural fistula stops, and so then after that, in CMC, actually, one of the residents suggested instead of removing the tube or keep it in a bottle without water seal, to see whether lung is collapsing. The most important thing is whether the lung is fully expanded or not. If it is collapsing, you change that back into a water seal and apply mild suction. That's one thing. The other thing is, as Krishna said, how to deal with the bronchopleural fistula. Most of the surgeons don't believe that immediate operation is much better than any glue or something applied bronchoscopically. And then the chronic leak, hem uh, tubes are not very commonly practiced now. I read something like Mini 500. I don't know what it is. Is it anything like called Mini 500, a portable chest drainage system with suction? Is it? Have you heard it or not?
Sorry, didn't get you, sir. What did you say?
Mini 500.
Mini
It is
500.
a portable tube system with suction,
No, I don't know. No.
Okay, all right. Then you didn't do something about the reoperation. That's the last thing, because most of them can be treated by conservative. If the lung is already expanded, then, and if it's going to collapse again, pleurodesis, either by chemical or, of course, tetracycline is not available now, by doxycycline. Or you can do VATS also, and do even prolectomy, or a tag powder is directly applied, that can be done. Okay.
One important thing that I want to tell everyone, because most of you are cardiothoracic residents, is not to clamp the tube at any time. Okay, that was practiced by some surgeons in UK earlier, and then before removal to clamp the tube and then remove it. It is to be detested. No, some people even here probably do that, but it is never to be clamp any tube. The only time you clamp a tube is after pneumonectomy to prevent pendulum movement. Otherwise, never ever clamp a tube. And the other thing, as Jairaj sir said about emptying the bottle, in the olden days we used to do that, but when converting an ICD into an open tube drainage, so that allow the patient to ambulate and go home. In that situation, if you empty the bottle, allow it to be exposed to the atmospheric air, if the lung stays adherent and only the small residual space is on top, then you are able to cut the tube and convert it into an open tube and send him home. Otherwise, you have to reapply the suction. That is how it is done, and it has to be done after a minimum of 3 weeks of underwater seal drainage. Otherwise, the lung will definitely go down. So that is